type 2 uncompensated diabetes, visual acuity 0.3 in one eye, 0.4 in 0.5 in the left eye. IOP is 16 millimeter. He has vitritis, and the blood pressure was fine. It was a color picture, some hemorrhage, phlegm hemorrhage, and his fluorescein angiography. So what do you think? It's diabetic retinopathy?
Yeah.
I would say yes. But we always have to decide based on multimodal imaging. So this is the ICG, fluorescein, both eyes, but the OCT is quite strange. It's not actually something that we expect in a diabetic retinopathy with retinoschisis. So we did a series of, and you see quite strange in a diabetic patient. So the differential diagnosis was bilateral optic pit because of the schisis, non-proliferative, and it's quite rare. Bilateral optic pit is not so common. Probably I've never seen. But non-proliferative diabetic retinopathy, malignant hypertensive chorioretinopathy, bilateral CRVO was quite impossible and not schisis, perifibritis, we didn't see, vitreoretinal degeneration, or paraneoplastic retinopathies. So here it's the situation around the optic nerve, and it was quite close to the optic pit situation where we actually have such a characteristics schisis, and also the detachment, neurosensory detachment of the forehead. But we couldn't find any pit. So we think, it's a schisis. So I mean, while we were looking for, genetic tests and all these kind of things, we said, why don't we give Truzop? Because if it's a retinoschisis, inherited retinoschisis, Truzop is working very well. So let's try. After 1 month, nothing. Actually, it was also increasing in the left eye, the neurosensory detachment with the schisis. So in the meantime, all the exam came back, so you see everything was negative, except for the, quantiferon was positive, the MAN2 was positive, and so the HLA B51 was positive, and it was a presumed tuberculosis in diabetes, so we actually gave a quadruple drug therapy. And then it was done for, after 1 month, the same fluorescein, actually probably some more microanalysis and more intraretinal fluid in both eyes. And the schisis was actually even worse. And the detachment also now it's more extended in the left eye. So at that point, you see it's very, our internist says, I found another exam that I didn't pay attention, and he has a gamma spike in the serum protein electrophoresis with an IgM monoclonal component, elevated erythrocyte sedimentation rate, and normal chromic, normal cystic anemia, and actually this was a Waldenstrom, Macroglobulinemia. So you see, and remember, it takes 6 months to understand what it was. So patients start to do plasmapheresis, and our colleagues were impressed by the density of his blood, and in fact he has to do plasmapheresis more than once. So here 1 month later, and after 6 months, you actually start to see some never, he actually did a little bit better, but never ever was flattened down. So this is the values of macroglobulinemia. And remember, retinoschisis is quite unusual in those patients. Now, in diabetic patients. Now, just to show the case of a PCV laser. The PCV lesion with ICG and after the treatment was laser, just laser, and here is the effect of the treatment before and after. You see, that is the grace level that you want to reach as maximum. You don't want to have more. And you are able to close all the polypoidal lesion that you want. Just very gentle and not being extra aggressive. So that's it.
Giovanni, what is the mechanism for the retinoschisis in Waldenstrom's?
It seems that it's due to the fact that you have a high density blood. There is no normal flow from the retina to the choroid, and so it's a kind of
Exoplasmic stasis.
exactly stasis. Yes.
Interesting. Yeah. I've never seen a Waldenstrom's causing retinoschisis. Anyone?
I thought it would cause more vein occlusion.
More vein occlusion, possibly. Yeah, that's one of the presentations. Any more presentations? Any more cases?